Question 1. A 5-year-old child presents with rapid breathing, retractions, and nasal flaring. The child is alert but anxious and unable to speak in full sentences. What is the most likely cause of these symptoms? A. Hypovolemic shock. B. Asthma exacerbation. C. Respiratory distress. D. Cardiac tamponade. Answer: C. Respiratory distress. The question describes classic signs of respiratory distress, characterized by increased work of breathing, rapid breathing, retractions, nasal flaring, and altered mental status, anxious, unable to speak in full sentences. While asthma exacerbation falls under this umbrella, respiratory distress is the broader, most accurate description of the child's current state. Hypovolemic shock typically presents with tachycardia and poor perfusion, while cardiac tamponade might show muffled heart sounds and JVD. For instance, seeing shallow, rapid breaths and chest wall retractions immediately signals a breathing problem needing attention. Remember that these signs indicate the body is working very hard to get enough air. Question 2. During a PALS assessment, you find a child who is unresponsive, apneic, and pulseless. What is the first medication you should administer according to the PALS guidelines? A. Amiodarone. B. Lidocaine. C. Epinephrine. D. Atropine. Answer: C. Epinephrine. The question identifies a pediatric patient in cardiac arrest, unresponsive, apneic, pulseless, which requires immediate resuscitation. According to the PALS cardiac arrest algorithm, epinephrine is the first-line drug for all pediatric cardiac arrests, regardless of the underlying rhythm. Epinephrine increases heart rate, contractility, and systemic vascular resistance, improving the chances of successful resuscitation. For example, administering epinephrine quickly can help restore some blood flow to vital organs during CPR. Always reach for epinephrine first when a child's heart has stopped. Question 3. What is the recommended initial fluid bolus volume for a child in hypovolemic shock? A. 5 milliliters per kilogram. B. 10 milliliters per kilogram. C. 20 milliliters per kilogram. D. 30 milliliters per kilogram. Answer: C. 20 milliliters per kilogram. This question tests knowledge of fluid resuscitation volumes for pediatric shock. The keyword initial fluid bolus indicates the first step in managing hypovolemia, and the PALS guideline specifies 20 milliliters per kilogram as the standard starting dose for isotonic crystalloids like normal saline or lactated ringers. This volume is given rapidly over 5 to 10 minutes to improve intravascular volume and perfusion. For example, for a 10 kilograms child, you would give a 200 milliliters bolus quickly. Remember that 20 milliliters per kilogram is the magic number for that first push of fluids in shock. Question 4. A 2-year-old child is brought to the emergency department with a high fever, rash, and lethargy. The child has poor skin turgor and delayed capillary refill. Which type of shock is most likely? A. Distributive shock. B. Obstructive shock. C. Cardiogenic shock. D. Hypovolemic shock. Answer: D. Hypovolemic shock. The child's presentation includes fever and rash, but the key indicators for the type of shock are poor skin turgor and delayed capillary refill, which point towards a significant loss of intravascular fluid volume. Hypovolemic shock results from decreased circulating volume, often due to dehydration from fever or vomiting. While fever and rash can be seen in sepsis, a type of distributive shock, the signs of dehydration strongly suggest fluid loss is the primary issue here. Think of dehydration from a stomach bug causing these symptoms. That's hypovolemic shock. Always check skin elasticity and capillary refill to assess fluid status. Question 5. What is the correct compression rate for pediatric cardiopulmonary resuscitation, CPR? A. 60 to 80 compressions per minute. B. 80 to 100 compressions per minute. C. 100 to 120 compressions per minute. D. 120 to 140 compressions per minute. Answer, C. 100 to 120 compressions per minute. This question focuses on the fundamental technique of pediatric CPR, specifically the compression rate. Current PALS guidelines recommend a rate of 100 to 120 compressions per minute for both single rescuers and two rescuers performing CPR on infants and children. This rate ensures adequate cardiac output and aims to mimic the natural heart rate. For example, imagine counting 1 and 2 and 3. About twice per second. Keeping the pace brisk but consistent is key to effective CPR. Question 6. A 6-month-old infant presents with inspiratory stridor, hoarseness, and a barking cough. The symptoms are worse at night. What is the most likely diagnosis? A. Epiglottitis. B. Bacterial tracheitis. C. Foreign body aspiration. D. Croup, laryngotracheobronchitis. Answer, D. Croup, laryngotracheobronchitis. The characteristic symptoms of inspiratory stridor, a high-pitched noise during inhalation, hoarseness, and a barking cough, especially when worse at night, are classic signs of croup. Croup is a viral illness causing inflammation and swelling of the upper airway, specifically the larynx and trachea. Epiglottitis typically presents with drooling, difficulty swallowing, and a toxic appearance, while foreign body aspiration often has a sudden onset with choking. For instance, hearing that seal-like barking cough makes croup highly probable. Remember the barking cough and stridor as hallmarks of croup. Question 7. What is the correct depth for chest compressions in an infant, less than 1 year of age? A. Up to 1 inch, 5 cm. B. About 5 inches, 4 cm. C. About 2 inches, 5 cm. D. About 5 inches, 6 cm. Answer, B. About 5 inches, 4 cm. This question addresses the proper technique for chest compressions in infants during CPR. The PALS guidelines recommend a compression depth of approximately 1/3 the anterior-posterior diameter of the chest, which translates to about 5 inches or 4 centimeters for infants. This depth is crucial for effectively circulating blood without causing injury. For example, you should aim to depress the sternum roughly 5 inches down. A good rule of thumb is to compress about 1/3 of the chest's depth. Question 8. A 3-year-old child collapses after choking on a piece of hot dog. Bystanders state they performed back blows and abdominal thrusts. The child remains unresponsive. What is the next step? A. Administer oxygen via non-rebreather mask. B. Begin chest compressions. C. Perform a finger sweep of the mouth. D. Provide rescue breaths only. Answer, B. Begin chest compressions. The scenario describes a child who experienced a choking episode, became unresponsive, and likely has an airway obstruction causing cardiac arrest. The keyword here is unresponsive following choking, suggesting CPR is needed. According to PALS guidelines for foreign body airway obstruction, FBAO, leading to arrest, Chest compressions should be initiated immediately, similar to standard CPR. Each set of compressions may help dislodge the object. For instance, think of the CPR cycle: compressions first when the child is unresponsive. Always start compressions if the child is unresponsive after choking. Question 9. Which rhythm requires immediate defibrillation in a child? A. Asystole. B. Pulseless electrical activity, PA. C. Ventricular fibrillation, VF. D. Symptomatic bradycardia. Answer: C. Ventricular fibrillation, VF. The question asks to identify the shockable rhythm in pediatric arrest. Ventricular fibrillation, VF, is characterized by chaotic electrical activity in the ventricles, leading to ineffective pumping and loss of pulse. PALS guidelines clearly state that VF and pulseless ventricular tachycardia, pulseless VT, are the only rhythms requiring immediate electrical defibrillation. Asystole and PEA are treated with medications and CPR, not shocks. For example, VF looks like a messy, wiggly line on the monitor and needs an electrical shock. Remember, VF/pulseless VT gets a shock, others get meds and CPR. Question 10. What is the initial dose of epinephrine for a 15 kg child in cardiac arrest? A. 0, 15 mg 4/IO. B. 0, 30 mg 4/IO. C. 1, 5 mg 4/IO. D. 3 mg 4/IO. Answer: A. 0, 15 mg 4/IO. This question requires calculating the correct initial dose of epinephrine based on the child's weight for cardiac arrest. The PALS guideline dose is 0.01 mg/kg, either intravenously, 4, or intraosseously, IO. For a 15 kg child, this calculation is 15 kg * 0.01 mg/kg equals 0.15 mg. Higher doses are used in specific situations or for different routes. For instance, 0.15 mg is roughly equivalent to 1 milliliter of the 1,10,000 concentration. Always calculate the 0.01 mg/kg dose for initial arrest management. Question 11. A 4-year-old child has a sudden onset of difficulty breathing, drooling, and is sitting upright, leaning forward. The child appears toxic and has a high fever. What is the most concerning potential diagnosis? A. Croup. B. Anaphylaxis. C. Epiglottitis. D. Pneumonia. Answer: C. Epiglottitis. The key signs presented: sudden onset, drooling, tripod position, sitting upright, leaning forward, muffled voice, and toxic appearance, are highly suggestive of epiglottitis, a life-threatening inflammation of the epiglottis. This condition can rapidly obstruct the airway. Croup typically has a barking cough and stridor but usually looks less toxic. Anaphylaxis involves hives and wheezing, and pneumonia causes crackles and consolidation. For example, a child refusing to lie down and drooling excessively needs immediate airway assessment for epiglottitis. Remember the classic tripod position and drooling with suspected epiglottitis. Question 12. What is the recommended timing for the second dose of epinephrine in a child with pulseless VT or VF that has not converted after the first shock and CPR cycle? A. Immediately after the first shock. B. After 2 minutes of CPR. C. After 5 minutes of CPR. D. After defibrillation is attempted again. Answer: B. after 2 minutes of CPR. This question relates to the PALS algorithm for shockable rhythms, VF/pulseless VT. Following the initial shock and a 2-minute cycle of CPR, the second dose of epinephrine is administered. This timing ensures that CPR efforts are maintained to improve perfusion before reassessing for a shockable rhythm. For example, after the first shock, you perform CPR for 2 solid minutes before giving the next drug or checking the rhythm again. Stick to the 2-minute cycles between shocks and interventions. Question 13. A 7-year-old child is experiencing moderate respiratory distress with wheezing unresponsive to initial inhaled bronchodilators. The child has a history of asthma. What medication should be considered next? A. For normal saline bolus. B. Oral glucose. C. For epinephrine infusion. D. Intramuscular, IM, epinephrine. Answer, D. Intramuscular, IM, epinephrine. The scenario describes an asthma exacerbation with persistent wheezing despite initial treatment. In severe or refractory asthma attacks, IM epinephrine can be very effective by causing bronchodilation. While 4-epinephrine infusion might be used in critical care, IM administration is a standard PALS intervention for moderate to severe exacerbations. A fluid bolus is for shock, oral glucose for hypoglycemia, and epinephrine is not standard for non-shockable bradycardia. For instance, giving epinephrine in the thigh muscle can quickly open up constricted airways. Consider IM epinephrine when breathing is still very difficult after initial treatments. Question 14. What is the correct dose of amiodarone for a child in refractory VF or pulseless VT? A. 5 mg per kilogram 4/IO bolus. B. 10 mg per kilogram 4/IO bolus. C. 0.1 mg/kg 4/IO bolus. D. 1 mg per kilogram 4/IO bolus. Answer. A. 5 mg per kilogram 4/IO bolus. This question tests the knowledge of PALS drug dosages for specific arrhythmias. Amiodarone is used for refractory ventricular fibrillation, VF, or pulseless ventricular tachycardia, VT, after shocks and epinephrine have been given. The recommended dose is a 5 mg per kilogram 4/IO bolus, which can be repeated up to 2 times if needed. For example, for a 20 kg child, you would administer 100 mg, 5 mg/kg * 20 kg. Remember 5 mg per kilogram is the dose for amiodarone in shockable rhythms. Question 15. A child presents with stridor, a muffled voice, and drooling. They are sitting upright, leaning forward. Which action should be avoided? A. Administering oxygen via blow-by. B. Preparing for intubation. C. Giving an IM injection. D. Offering water to drink. Answer, D. Offering water to drink. The symptoms described strongly suggest epiglottitis, a serious condition involving swelling around the epiglottis that can lead to complete airway obstruction. Offering water could precipitate laryngospasm or airway closure in a child with epiglottitis. Actions like blow-by oxygen, preparing for potential intubation, and avoiding IM injections, if the child is agitated and might worsen airway control, are more appropriate. For instance, a child struggling to swallow is unlikely to tolerate drinking. Never give anything by mouth to a child suspected of having epiglottitis due to the high risk of airway compromise. Question 16. What is the goal of the primary survey in pediatric assessment? A. To gather detailed history from the caregiver. B. To identify and treat life-threatening conditions. C. To establish definitive vascular access. D. To perform a complete head-to-toe examination. Answer B. To identify and treat life-threatening conditions. The primary survey, often remembered by the ABCDE approach, airway, breathing, circulation, disability, exposure, is designed for the rapid identification and immediate management of conditions that pose an imminent threat to life. Keywords like primary and the focus on immediate threats guide this answer. While history and a full exam are important, secondary survey, they come after addressing life-blocking issues. For example, ensuring the airway is open takes precedence over checking reflexes. The primary goal is always to stabilize immediate threats first. Question 17. A neonate, less than 28 days old, has bradycardia with signs of poor perfusion. What is the recommended initial treatment? A. Epinephrine. B. Atropine. C. Chest compressions. D. Adenosine. Answer C. Chest compressions. Neonatal bradycardia, especially with poor perfusion, is critical and requires immediate intervention. While epinephrine is the drug of choice for pediatric bradycardia, the PALS guidelines emphasize starting chest compressions immediately if the heart rate is below 60 bpm with poor perfusion in a neonate or infant, even before or concurrent with starting medications. This is because the bradycardia is often secondary to hypoxia, and improving ventilation and perfusion via compressions is paramount. For example, if the baby's heart rate is 50 and they aren't pink, start compressions right away. Remember, slow heart rate plus poor perfusion in a baby means start compressions immediately. Question 18. What is the correct ventilation rate for a child requiring rescue breaths, e.g., in respiratory arrest but with a pulse? A. 1 breath every 2 to 3 seconds. B. 1 breath every 5 to 6 seconds. C. 1 breath every 8 to 10 seconds. D. 1 breath every 12 to 15 seconds. Answer B. 1 breath every 5 to 6 seconds. This question addresses the appropriate ventilation rate for pediatric patients who are not in cardiac arrest but require assisted breathing. The PALS guideline for rescue breathing is 1 breath every 5 to 6 seconds, or 10 to 12 breaths per minute, for children and infants. This rate ensures adequate oxygenation without causing hyperventilation or excessive positive pressure ventilation, which can lead to barotrauma or decreased venous return. For example, giving a breath about once every 5 heartbeats helps maintain oxygen levels. Remember to breathe for them about 10 to 12 times each minute. Question 19. A child appears cyanotic and has weak pulses. The pediatric assessment triangle reveals abnormal breathing. What is the most critical initial action? A. Obtain a rectal temperature. B. Provide 100% oxygen via non-rebreather mask. C. Establish intraosseous (IO) access. D. Begin chest compressions. Answer B. Provide 100% oxygen via non-rebreather mask. Cyanosis and abnormal breathing strongly suggest hypoxia, a critical threat identified in the primary survey, specifically the breathing component of the PAT. Providing high-concentration oxygen is the immediate, life-saving intervention to improve oxygen saturation. While weak pulses might indicate shock needing fluids, C, or CPR, D, and temperature is part of assessment, addressing the most apparent life threat, hypoxia, with oxygen comes first. For example, giving extra oxygen directly addresses the lack of pink color. Always prioritize oxygen for cyanosis and breathing problems. Question 20. What is the initial recommended dose of adenosine for a child diagnosed with stable supraventricular tachycardia, SVT? A. 0.05 mg/kg/IO push. B. 0.1 mg/kg/IO push. C. 0.2 mg/kg/IO push. D. 0.3 mg/kg/IO push. Answer B. 0.1 mg/kg/IO push. The question tests the initial medication dose for stable supraventricular tachycardia, SVT, in children. Adenosine is used to slow conduction through the AV node, often terminating the arrhythmia. The PALS guideline recommends an initial 4/IO dose of 0.1 mg/kg, followed by a second dose of 0.2 mg/kg if the first is ineffective. It's given as a rapid bolus followed by a saline flush. For example, for a 10 kg child, the first dose would be 1 mg. Remember 0.1 mg/kg is the starting point for adenosine in SVT. Question 21. What is the primary difference between type 1 and type 2 respiratory failure in children? A. Type 1 involves low oxygen, type 2 involves high carbon dioxide. B. Type 1 involves high carbon dioxide, type 2 involves low oxygen. C. Type 1 is caused by pneumonia, type 2 by asthma. D. Type 1 is acute, type 2 is chronic. Answer A. Type 1 involves low oxygen, type 2 involves high carbon dioxide. This question distinguishes the two main types of respiratory failure. Type 1, hypoxemia, failure occurs when the lungs cannot adequately oxygenate the blood, low PaO2, often due to conditions like pneumonia or pulmonary edema. Type 2, hypercapnia, failure occurs when the lungs cannot adequately remove carbon dioxide, high PaO2, often due to hypoventilation like in severe asthma or neuromuscular disease. For example, a child drowning likely has type 1 failure, while severe sleep apnea might cause type 2. Remember, type 1 equals low O2, type 2 equals high CO2. Question 22. You are managing a child in shock. After the initial 20 milliliters per kilogram crystalloid bolus, the child remains hypotensive. What is the most appropriate next step? A. Administer a second 20 milliliters per kilogram bolus of crystalloid. B. Start an epinephrine infusion. C. Administer a 10 milliliters per kilogram bolus of colloid. D. Perform chest compressions. Answer A. Administer a second 20 milliliters per kilogram bolus of crystalloid. The question describes a child who is still hypotensive after receiving an initial fluid bolus, indicating persistent shock. According to PALS guidelines for hypovolemic or likely hypovolemic shock, repeated boluses of isotonic crystalloids, 20 ml/kg, are indicated until perfusion improves or signs of fluid overload appear. Epinephrine infusion is typically reserved for shock refractory to fluids or specific types like distributive shock. Colloid is not the standard second step, and chest compressions are for cardiac arrest. For instance, giving another bag of fluid is often necessary to adequately restore circulating volume. Always consider giving a second, or third fluid bolus if the patient is still showing signs of shock. Question 23. What is the recommended dose for the second maintenance dose of epinephrine for /IO infusion for a child in shock? A. 0.01 mg/kg/min. B. 0.1 mg/kg/min. C. 1 microgram per kilogram per minute. D. 10 micrograms per kilogram per minute. Answer B. 0, 1 mcg/kg/min. This question addresses the PALS algorithm for managing shock, specifically the maintenance infusion rate for epinephrine. After initial boluses, if the child remains hypotensive, an infusion may be started. The PALS guidelines suggest an initial infusion rate of 0, 1 mcg/kg/min for epinephrine, which can be titrated up or down based on the child's response, e.g., heart rate, blood pressure. Higher doses are used for different indications or if the initial dose is insufficient. For example, starting at 0, 1 mcg/kg/min is a common starting point to support blood pressure. Remember 0, 1 mcg/kg/min is a typical starting dose for epinephrine infusion in pediatric shock. Question 24. A 6-year-old child is brought in after a fall. They have a large abrasion on the leg with moderate bleeding and appear pale and anxious. What is the priority? A. Administer pain medication. B. Clean the wound thoroughly. C. Control the bleeding. D. Check vital signs. Answer C. Control the bleeding. The child presents with pallor and anxiety, accompanied by bleeding. While checking vital signs, D, is part of assessment, and cleaning the wound, B, and pain relief, A, are important, the most immediate priority is controlling the hemorrhage. Significant external bleeding can lead to hypovolemic shock, which is a life-threatening condition. Addressing the bleeding directly improves circulation and stabilizes the patient. For example, applying direct pressure stops blood loss quickly. Always address active, significant bleeding first to prevent shock. Question 25. What is the primary characteristic of respiratory syncytial virus, RSV, infection in infants? A. High fever and sore throat. B. Wheezing and cough, often progressing to bronchiolitis. C. Sudden onset of barking cough and stridor. D. Joint pain and rash. Answer B. Wheezing and cough, often progressing to bronchiolitis. This question focuses on identifying a common pediatric respiratory illness. RSV is a major cause of lower respiratory tract infections in infants, typically causing symptoms like cough, wheezing, and sometimes bronchiolitis, inflammation of the small airways. While fever can occur, the prominent feature is the lower airway involvement. Barking cough and stridor suggest croup, and joint pain/rash are not typical primary RSV symptoms. For instance, many infants admitted with wheezing and difficulty breathing have RSV. Remember, RSV often causes wheezing and breathing trouble in babies. Question 26. How often should chest compressions be coordinated with ventilations in a 2-rescuer CPR scenario for an infant or child? A. 15:1 ratio. B. 30:1 ratio. C. 30:2 ratio. D. 15:2 ratio. Answer D. 15:2 ratio. The question asks about the compression to ventilation ratio for pediatric CPR when 2 rescuers are present. The PALS guidelines specify a ratio of 15 compressions to 2 breaths for 2 rescuer CPR in infants and children. This ratio is adjusted from the adult ratio to provide more frequent ventilation support suitable for pediatric patients, who often have respiratory issues. For example, 1 rescuer performs 15 quick compressions while the second rescuer delivers 2 breaths. Remember, 15 compressions followed by 2 breaths is the 2-rescuer pediatric ratio. Question 27. A child has a narrow complex tachycardia with a heart rate of 190 bpm. They are alert and well perfused. What is the most likely diagnosis? A. Sinus tachycardia. B. Ventricular tachycardia, VT. C. Supraventricular tachycardia, SVT. D. Atrial fibrillation. Answer, C. Supraventricular tachycardia, SVT. The scenario describes a narrow complex tachycardia, meaning the QRS complex on an ECG is narrow, with a rapid heart rate, 190 bpm, in an otherwise stable child. SVT is the most common narrow complex tachycardia in children and typically presents with abrupt onset and offset. Sinus tachycardia is usually related to a cause like fever or pain and is often responsive to treating the underlying issue. VT typically presents with a wide complex. For example, an otherwise healthy child suddenly developing a very fast, regular heartbeat is often SVT. Remember, narrow QRS plus fast rate plus stable child equals likely SVT. Question 28. What is the primary goal of the secondary survey? A. To immediately secure the airway. B. To rapidly assess and manage life-threatening conditions. C. To gather detailed information about the illness/injury after initial stabilization. D. To administer all necessary medications. Answer, C. To gather detailed information about the illness/injury after initial stabilization. The secondary survey involves a more thorough head-to-toe examination and history-taking, but crucially, it is performed after the primary survey is complete and life-threatening conditions have been addressed. Keywords like detailed information and after initial stabilization distinguish it from the primary survey's goal. This systematic approach helps gather clues to the underlying cause of the patient's condition. For example, asking the caregiver about allergies or previous medical history happens during the secondary survey. The secondary survey digs deeper once the patient is stable enough. Question 29. Which condition is characterized by inflammation of the small airways, often caused by RSV, leading to wheezing and crackles in infants? A. Croup. B. Pneumonia. C. Bronchiolitis. D. Tracheitis. Answer, C. Bronchiolitis. The question describes bronchiolitis, defining it by inflammation of the small airways, bronchioles, its common cause, RSV, and characteristic symptoms like wheezing and crackles, particularly in infants. Croup affects the upper airway, larynx/trachea, causing stridor and barking cough. Pneumonia involves inflammation of the lung parenchyma, alveoli. Tracheitis is inflammation of the trachea. For instance, a 4-month-old with a cold who develops noisy breathing and rapid respiratory rate likely has bronchiolitis. Remember, bronchiolitis means inflammation of the small breathing tubes. Question 30. What is the recommended dose of naloxone, Narcan, for suspected opioid overdose in a child? A. 0.01 mg/kg/IM/IN. B. 0.1 mg/kg/IM/IN. C. 1 mg/kg/IM/IN. D. 10 mg/kg/IM/IN. Answer, B. 0.1 mg/kg/IM/IN. This question addresses the management of opioid overdose, where naloxone is the reversal agent. The PALS guideline dose for naloxone is 0.1 mg/kg via intravenous, intramuscular, or intranasal routes, with a maximum single dose typically noted. A lower initial dose might be used, but 0.1 mg/kg is the standard PALS recommendation for administration. Higher doses are available but usually reserved for specific circumstances or different formulations. For example, for a 10 kilograms child, you'd give 1 milligram. A dose of 0.1 mg/kg is standard for reversing opioid effects. Question 31. A child presents with signs of shock but has a known history of a severe allergic reaction. What type of shock should be suspected? A. Hypovolemic shock. B. Cardiogenic shock. C. Distributive shock, anaphylactic. D. Obstructive shock. Answer, C. Distributive shock, anaphylactic. The combination of shock symptoms, hypotension, poor perfusion, with a history suggestive of an allergic reaction, though not explicitly stated, the prompt implies it, points towards distributive shock, specifically anaphylaxis. Anaphylaxis causes widespread vasodilation, leading to a relative hypovolemia and shock. While the initial presentation might mimic hypovolemic shock, the underlying cause is different. For example, a child stung by a bee who then becomes hypotensive and develops hives is in anaphylactic shock. Remember, allergic reactions can cause shock through vasodilation. Question 32. What is the initial energy dose for defibrillation in a child? A. 1 J/kg. B. 2 J/kg. C. 4 J/kg. D. 10 J/kg. Answer, B. 2 J/kg. This question concerns the energy settings for defibrillation in pediatric patients. According to PALS guidelines, the initial dose of energy for defibrillation is 2 joules per kilogram, J/kg, of body weight. If the initial attempt is unsuccessful, the dose is increased for subsequent attempts. Higher doses might be used for specific situations or after multiple failed attempts, but 2 J/kg is the standard starting point. For example, for a 15 kilograms child, the first shock should be set at 30 joules, 2 J/kg * 15 kilograms. Always start defibrillation at 2 joules per kilogram. Question 33. A child develops sudden onset of seizures that last longer than 5 minutes. What is this condition called? A. Febrile seizure. B. Simple partial seizure. C. Status epilepticus. D. Breath-holding spell. Answer, C. Status epilepticus. Status epilepticus is defined as a seizure that lasts for an extended period or occurs in rapid succession without recovery between seizures. The key feature is the duration. Seizures lasting longer than 5 minutes, as described in the question, meet the criteria. Febrile seizures are related to fever, simple partial seizures are brief and localized, and breath-holding spells are benign events. For example, a seizure that doesn't stop on its own within 5 minutes requires immediate medical intervention. Remember, 5 minutes or more of continuous seizure activity is status epilepticus. Question 34. What is the recommended first-line medication for a child experiencing status epilepticus? A. Diazepam, Valium. B. Phenobarbital. C. Lorazepam, Ativan. D. Midazolam, Vers D. Answer, D. Midazolam, Vers D. The question asks for the first-line medication to stop prolonged seizures, status epilepticus. PALS guidelines prioritize rapid-acting benzodiazepines. While diazepam and lorazepam are effective, midazolam is often preferred due to its availability as an intramuscular, IM, preparation, allowing for rapid administration outside a hospital setting or when IV access is difficult. The goal is to stop the seizure quickly. For example, giving midazolam into the muscle can stop a seizure within minutes. Midazolam is often the first choice for stopping seizures fast, especially if access isn't immediate. Question 35. How should you manage a choking infant, less than 1 year, who is conscious but unable to cough or cry? A. Give 5 back blows followed by 5 chest thrusts. B. Give 5 abdominal thrusts followed by 5 back blows. C. Perform blind finger sweeps in the mouth. D. Give 2 rescue breaths immediately. Answer. A. Give 5 back blows followed by 5 chest thrusts. The question describes a conscious choking infant with signs of severe obstruction, unable to cough/cry. The PALS algorithm for foreign body airway obstruction, FBAO, in infants involves alternating between 5 back blows, given between the infant's shoulder blades, and 5 chest thrusts, similar to chest compressions but softer. Abdominal thrusts are for older children. Finger sweeps are avoided due to the risk of pushing the object further. For example, holding the infant face down on your forearm and giving back blows is the first step. Remember the 5 back blows and 5 chest thrust sequence for choking infants. Question 36. What is the PALS recommendation for sick sinus syndrome management in a pediatric patient presenting with bradycardia? A. Immediate chest compressions. B. Epinephrine or dopamine infusion. C. Atropine. D. Cardioversion. Answer. C. Atropine. Sick sinus syndrome can cause symptomatic bradycardia. Atropine is the first-line medication recommended by PALS guidelines for treating symptomatic bradycardia resulting from increased vagal tone or sinus node dysfunction, provided the heart rate is above the threshold requiring compressions. Epinephrine or dopamine infusions are typically used if atropine is ineffective or for more severe bradycardia. Cardioversion is for tachyarrhythmias. For example, atropine works by blocking the vagus nerve's slowing effect on the heart. Think atropine first for symptomatic bradycardia unless the patient is arrest/near arrest. Question 37. A child experiences a burn injury covering their entire back and both arms. What is the estimated body surface area, BSA, percentage affected using the rule of nines for pediatrics? A. 9%. B. 18%. C. 27%. D. 36%. Answer. D. 36%. This question assesses the application of the rule of nines for estimating burn surface area in children. According to the standard pediatric rule of nines, the entire back constitutes 18% of the body surface area, and each arm accounts for 9%. Therefore, a burn covering the entire back and both arms would affect 18%, back, plus 9%, right arm, plus 9%, left arm, equals 36% of the total body surface area. This calculation helps guide fluid resuscitation and treatment decisions. For instance, knowing the percentage is crucial for calculating the amount of fluids needed. Remember the back is 18% and each arm is 9% in children using this rule. Question 38. What is the appropriate initial dose of epinephrine for a child weighing 22 pounds, 10 kg, with symptomatic bradycardia? A. 0.1 mg 4/IO. B. 0.2 mg 4/IO. C. 1 mg 4/IO. D. 2 mg 4/IO. Answer. A. 0.1 mg 4/IO. The question asks for the correct initial dose of epinephrine for symptomatic bradycardia based on weight. The PALS guideline is 0.1 0.1 mg/kg/IO. For a child weighing 10 kilograms, the calculation is 10 kilograms * 0.1 mg/kg equals 0.1 mg. This dose helps increase the heart rate and improve perfusion when the heart rate is too slow and causing symptoms. For example, 0.1 mg is a small vial, often pre-filled in emergency kits. Always calculate epinephrine doses for bradycardia using 0.1 mg/kg. Question 39. Which assessment finding is most indicative of impending airway obstruction in a child with croup? A. Mild stridor when calm. B. Barking cough. C. Drooling and inability to swallow secretions. D. Wheezing on expiration. Answer: C. Drooling and inability to swallow secretions. While stridor and a barking cough are characteristic of croup, the inability to manage secretions, drooling, and a muffled voice suggest the swelling is severe enough to obstruct the airway significantly, potentially leading to complete blockage. This is a critical sign indicating a potential emergency. Wheezing usually indicates lower airway obstruction, like asthma or bronchiolitis. For example, seeing saliva pool around a child's mouth because they can't swallow it indicates severe throat swelling. Drooling and difficulty swallowing are red flags for worsening airway obstruction in croup. Question 40. If force/IO access is significantly delayed in a pediatric patient in cardiac arrest, what is the recommended PALS dose of epinephrine administered via the endotracheal tube, ETT? A. 0.1 mg/kg. B. 0.1 mg/kg. C. 1 mg per kilogram. D. 2 mg per kilogram. Answer: C. 1 mg per kilogram. This question addresses the ETT administration route for epinephrine when force/IO access is delayed during pediatric resuscitation. The PALS guidelines state that if vascular access cannot be established promptly, epinephrine can be given via the endotracheal tube, but the dose must be 10 times the fore-dose. Therefore, the recommended ETT dose is 1 mg per kilogram. This larger dose attempts to compensate for potentially poorer absorption via the lungs compared to the vascular route. For example, for a 10 kg child, the ETT dose would be 10 mg. Always remember the dose increases tenfold when giving epinephrine via the ETT. Question 41. What is the main side effect associated with adenosine administration? A. Hypotension. B. Bradycardia. C. Flushing and a sense of impending doom. D. Bronchospasm. Answer: C. Flushing and a sense of impending doom. This question focuses on the common adverse effects of adenosine, a medication used for SVT. While it can cause transient bradycardia or hypotension, the most frequently reported and recognized side effects are a brief facial flushing and a feeling of chest pressure or impending doom, which are generally short-lived due to the drug's extremely short half-life. Bronchospasm is less common. For example, patients often report feeling weird for a few seconds after the injection. Remember that flushing and feeling strange are common, temporary effects of adenosine. Question 42. During the assessment of a child with respiratory distress, you hear inspiratory and expiratory wheezing. This finding is most suggestive of A. Croup. B. Epiglottitis. C. Bronchiolitis or asthma. D. Foreign body in the esophagus. Answer: C. Bronchiolitis or asthma. Wheezing, which is a continuous, high-pitched whistling sound heard during breathing, typically occurs when airflow is limited due to narrowed airways. Both bronchiolitis, common in infants, and asthma, common in older children, characteristically cause wheezing due to inflammation and constriction of the bronchioles or bronchi. Stridor, inspiratory noise, is more typical of upper airway issues like croup or epiglottitis. A foreign body might cause unilateral wheezing or diminished breath sounds. For instance, hearing wheezing during both inhalation and exhalation points to widespread narrowing in the lower airways. Remember, wheezing often means narrowed lower airways, seen in asthma and bronchiolitis. Question 43. What is the recommended maintenance fluid rate for a stable, non-febrile 10 kg child? A. 10 milliliters per hour. B. 40 milliliters per hour. C. 60 milliliters per hour. D. 100 milliliters per hour. Answer, B. 40 milliliters per hour. This question requires calculating the standard maintenance fluid rate using the 4-to-1 rule. For the first 10 kilograms of body weight, the maintenance rate is 4 milliliters per kilogram per hour. Therefore, for a 10 kilograms child, the calculation is 10 kilograms * 4 milliliters per kilogram per hour equals 40 milliliters per hour. This provides baseline hydration for metabolic needs. Rates are adjusted for children weighing more than 10 kilograms. For example, a 10 kilograms child needs 40 milliliters of fluid per hour. Remember the 4-to-1 rule. For milliliters per kilogram per hour for the first 10 kilograms. Question 44. Which clinical finding suggests a child may have cardiogenic shock? A. Warm extremities and bounding pulses. B. Cool extremities and weak pulses. C. Rapid breathing and clear lungs. D. Decreased heart rate. Answer, B. Cool extremities and weak pulses. Cardiogenic shock results from the heart's inability to pump effectively, leading to impaired cardiac output. This typically causes peripheral hypoperfusion, manifesting as cool extremities, pale or mottled skin, weak peripheral pulses, and potentially delayed capillary refill. Warm extremities and bounding pulses are more characteristic of distributive shock, like sepsis or anaphylaxis. While rapid breathing can occur, clear lungs are not definitive, and heart rate is usually increased in shock, unless bradycardia is the cause. For example, feeling cold hands and feet plus a weak pulse suggests the heart isn't pumping blood well to the periphery. Think cool and clammy with poor pulses for heart pump failure. Question 45. What is the primary intervention for a child with a complete airway obstruction, e.g., choking, who is conscious? A. Administer oxygen. B. Perform abdominal thrusts, Heimlich maneuver. C. Perform chest thrusts. D. Attempt endotracheal intubation. Answer, B. Perform abdominal thrusts, Heimlich maneuver. The question addresses the immediate management of a conscious child, over 1 year, with a complete airway obstruction. The keyword conscious and complete obstruction indicates the need for mechanical dislodgement of the object. For children over age 1, abdominal thrusts, the Heimlich maneuver, are the recommended intervention. Chest thrusts are used for infants, oxygen is for respiratory distress, and intubation is typically considered if thrusts fail or the child becomes unconscious. For example, performing the Heimlich maneuver can force air out rapidly to dislodge the object. Remember abdominal thrusts for conscious choking in older children. Question 46. What is the appropriate initial dose of dopamine for a child in shock if epinephrine is unavailable or ineffective? A. 2 to 5 mcg/kg/min. B. 5 to 10 mcg/kg/min. C. 10 to 15 mcg/kg/min. D. 15 to 20 mcg/kg/min. Answer B. 5 to 10 mcg/kg/min. Dopamine is an inotropic and vasoactive medication used in managing pediatric shock, often as a second-line agent if fluids and initial medications like epinephrine are insufficient or contraindicated. The PALS guidelines suggest starting dopamine at an infusion rate of 5 to 10 mcg/kg/min, titrating based on the patient's response, e.g., blood pressure, heart rate, perfusion. Lower doses might primarily increase heart rate, beta effects, while higher doses increase vascular resistance, alpha effects. For example, starting dopamine at a low-moderate dose helps support the heart's pumping action. Remember 5 to 10 mcg/kg/min is a common starting dose range for dopamine. Question 47. Which PALS team member is primarily responsible for obtaining a detailed patient history from the family? A. Team leader. B. Airway manager. C. Compressor. D. Data/timer person. Answer D. Data/timer person. While all team members contribute, the PALS team structure often assigns specific roles. The person designated as the data/timer person or sometimes the recorder typically takes responsibility for gathering the history from caregivers, documenting interventions, and tracking time intervals, allowing others to focus on the primary tasks like compressions and airway management. The team leader oversees overall management, the airway manager focuses on the airway, and the compressor performs CPR. For example, while CPR is ongoing, the timer person might quickly ask the parent about the events leading up to the collapse. Assigning roles ensures all tasks are covered efficiently. History taking often falls to the timer/recorder. Question 48. A child has a pulse rate of 180 bpm, a narrow QRS complex, and is now becoming hypotensive and less responsive after 10 minutes of SVT. What is the recommended intervention? A. Administer adenosine 0.1 mg/kg/IO. B. Administer epinephrine 0.01 mg/kg/IO. C. Perform synchronized cardioversion at 1 J/kg. D. Begin chest compressions. Answer C. Perform synchronized cardioversion at 1 J/kg. The child initially had stable SVT, narrow complex tachycardia, but has now deteriorated with hypotension and decreased responsiveness. This indicates the SVT is causing hemodynamic instability. The PALS algorithm recommends synchronized cardioversion starting at 1 J/kg for unstable tachycardias, even if they are narrow complex like SVT. Adenosine is for stable SVT, epinephrine is for bradycardia/arrest, and chest compressions are for pulseless rhythms. For example, delivering a controlled electrical shock timed to the heart's rhythm can often restore a normal heart rate quickly in unstable SVT. When a fast heart rhythm makes the child unstable, think cardioversion. Question 49. What vital sign parameter is most important to monitor during PALS resuscitation efforts? A. Respiratory rate. B. Blood pressure. C. Oxygen saturation. D. Temperature. Answer B. Blood pressure. While all vital signs are monitored, blood pressure is a key indicator of perfusion and overall hemodynamic status during resuscitation, especially in shock and arrest scenarios. It directly reflects the effectiveness of interventions like fluid boluses and medications, epinephrine, dopamine, aimed at restoring circulation. Oxygen saturation indicates oxygenation but not necessarily perfusion pressure. Respiratory rate is important but secondary to perfusion in shock. Temperature is important but usually addressed after immediate life threats. For example, a rising blood pressure after fluid boluses shows the intervention is working. Blood pressure is a critical gauge of successful resuscitation. Question 50. A 3-year-old child is apneic and pulseless. After 2 minutes of CPR and the first dose of epinephrine, the rhythm displayed is asystole. What is the next medication recommended by the PALS algorithm? A. Amiodarone 5 mg per kilogram. B. Atropine 0, 1 mg/kg. C. Epinephrine 0, 0.1 mg/kg. D. Lidocaine 1 mg per kilogram. Answer, C. Epinephrine 0, 0.1 mg/kg. The question describes a pediatric patient in cardiac arrest with asystole, following initial resuscitation efforts. Asystole is a flatline rhythm indicating no electrical activity, and it is treated similarly to PEA, pulseless electrical activity. According to the PALS cardiac arrest algorithm, the next step after the first dose of epinephrine and 2 minutes of CPR, if the rhythm remains asystole or PEA, is to administer another dose of epinephrine, 0.1 mg/kg 4/IO. Amiodarone, atropine, and lidocaine are used for specific shockable or bradycardic rhythms, not asystole. For example, continuing epinephrine every few minutes is standard care for asystole. Remember, epinephrine is the drug of choice for asystole and PEA.